Chapter 46, The Child with Cardiovascular Alteration. Remember, once that infant takes their first breath, the body changes over from fetal circulation to our circulation. Changes that may take place are listed on that screen. Please refer back to the videos on Moodle from earlier in the semester if you need to refresh on this. Congenital heart disease is known as CHD. 2 or 3 of these infants are symptomatic in the first year of life. CHD is a major cause of death in the first year of life after prematurity. Most common anomaly is ventricular septal defect. In 28% with CHD, another recognized anomaly is also present. For congenital, we're talking about anatomic, which is resulting in abnormal function. If it's acquired, it's a disease process. There can be from infection, autoimmune responses, environmental factors, and familial tendencies all can be things that can cause CHD. Heart failure is a heart's inability to circulate blood sufficient to maintain the metabolic demands on the body. It's typically caused from an underlying congenital defect that causes volume or pressure overload. It can be from an acquired disease, which we'll talk about shortly. Many times the signs of HF are very subtle and not always caught. Mild tachycardia at rest and with feedings may be noticed. Parents may notice feedings take longer and the child requires rest periods. They may not gain weight and they may be diagnosed with failure to thrive. Older kids can complain of shortness of breath. They can have orbital and facial edema, decreased urine output, cyanosis, and pallor. The diagnosis is determined by clinical history, physical examination, chest x-ray, ECG, and echo. They will also look at ABGs, electrolytes, CBC, the ESR, glucose, and calcium levels, and a UA. The management includes correcting the underlying cause as soon as they are able. The workload of the heart must be decreased, and we must improve that cardiac output to ensure sufficient blood flow to the vital organs. Oxygen may be used for some children. We'll talk about medications on the next slide. Digoxin is not used as frequently now due to the risk of dig toxicity, but some providers still favor it due to its rapid onset and ability to work well. It improves the cardiac output. It's available in elixir form or oral doses. You have to monitor for signs of toxicity. In infants and small children, the earliest signs include change in the rate and rhythm of the heartbeat. We'll monitor dig levels via their labs. It can be given IV or oral in divided doses over 24 hours for best results. A fall in potassium level enhances the effectiveness of dig, which increases the risk for dig toxicity. An increase in potassium will diminish the effectiveness of dig, so close monitoring of that potassium level is crucial. ACE inhibitors, they block the conversion of angiotensin 1 to angiotensin 2, causing vasodilation to occur, which will cause a decrease in that pulmonary and systemic vascular resistance. It will cause a decrease in blood pressure and a reduction of that afterload. Common meds used in children include captopril, enalapril, and lisinopril. The common side effects include hypotension, cough, and renal dysfunction. Beta blockers are another line of meds that may be added to the treatment plan. Most common ones are carvedilol and metoprolol. These will cause a decrease in heart rate, blood pressure, and vasodilation. Side effects include dizziness, headaches, and hypotension. Furosemide, the drug of choice for severe heart failure, they may need potassium supplements, but if they're taking an ACE inhibitor, the ACE will inhibit that blocks the action of aldosterone. Aldosterone typically aids in the decrease in the potassium levels, but with that ACE inhibitor will block the action of aldosterone, which will keep potassiums in even with the use of furosemide. Monitory eyes and nose, observe for signs of dehydration, and observe for signs of dig toxicity. Chlorothiazide is less frequently used, can cause hypokalemia, so monitor levels, monitor eyes and nose. They may need potassium supplements. You want to encourage foods high in potassium. Spironolactone it blocks aldosterone as well, so it keeps potassium. May be used with furosemide and chlorothiazide. Take several days to achieve the max. Actions do not give. So it may take several days to achieve. Some of the actions do not give potassium supplements with them. So sorry there. Nursing care management, improve cardiac function. So to do this, we're going to administer the correct dose of DIG. Be sure that dose is correct. You're going to watch for signs of toxicity, instruct parents on the correct use, monitor apical pulse prior to giving. Typically, it's not given if below 90 to 110 for infants and young children or below 70 for older children. Check the policy or orders for specific guidelines regarding this. Use apical pulse for 1 full minute. See the family-centered care box for administering DIG. Infants rarely will receive more than 1 ml. So if a dose is larger than that, have someone else check the dose. Monitor afterload. We do this by carefully monitoring blood pressure before and after administration of ACE inhibitors. Monitor electrolytes as well. Decrease cardiac demands. This means the infant needs to rest, so space your activities. Allow them to have uninterrupted sleep when able. Encourage parents to stay with the child. They may hold, rock, cuddle. Only change the linens when necessary. Feed at the first sign of their hunger so they don't get too fussy. Try to prevent excessive crying. You're going to minimize unnecessary stress. Monitor temp to avoid hyper or hypothermia, which can cause an increase in their O2 needs. Monitor for skin breakdown, which will be at increased risk with edema. Turn positions every 2 hours, and use of pressure-relieving mattress. To reduce respiratory distress, we need to do good assessment, positioning, and administering of O2. You'll provide the humidified O2. Monitor for signs of infection. Good hand washing. Give antibiotics if needed at regularly scheduled times to get blood levels more therapeutic. Maintain nutritional status. We'll do this by caloric needs are greater, so this can be a big challenge. An infant should be well rested before feeding, so feed soon after awakening, typically every 3 hours for infants. A soft preemie nipple may be needed to help make the feeding easier. May need to gavage feed infants to decrease their workload. Higher caloric formula may be used. If mom is breastfeeding, many times they will add breast milk to formula to enhance the caloric intake. Assist to promote fluid loss. We'll do this by monitoring I's and O's, daily weights at the same time each day. Monitor for signs of dehydration and electrolyte imbalance from the diuretics. May mix the elixir with fruit juice to hide the bitter taste and prevent the GI irritation. As far as support goes, the nurse needs to focus on reducing stress for the child, provide updates to parents, and include them in the plan of care as well if the child is age appropriate. Discharge instructions will include all of the education on these topics. Pulmonary hypertension is elevated blood pressure in the blood vessels of the lungs. It's diagnosed when the mean pulmonary arterial pressure exceeds 20 millimeters of mercury at rest. Normal is 15 millimeters of mercury. Can be caused by CHD, familial tendencies, or it's idiopathic. Over time, it can lead to vessel wall thickening, severe irreversible vasoconstriction, and vascular obstruction. This can cause a right to left shunting of the blood, which causes less blood to be pumped to the lungs. This can lead to heart failure in the child, and now treatment is geared towards treatment of that heart failure. They will need warfarin as well due to the risk of clotting with the obstruction in the vessels. The child should avoid strenuous activities. Cyanosis becomes visible when hemoglobin that is not bound to oxygen reaches a level of about 5 grams per deciliter, and the oxygen saturation level drops below 85%. It can occur when blood flow to the lungs is decreased or desaturated blood is pumped to the body. Cyanosis intensifies with crying in children with defects and is not resolved by providing oxygen at 100%. Complications of this is polycythemia, anemia, hypercyanotic spells, CNS injury, PAH, and endocarditis. Polycythemia happens as a compensatory response to the body when it has chronic hypoxia. The body wants to send out more RBCs so there are more sources to carry the oxygen. The increased RBC production increases the viscosity of the blood. Since this happens, there's less room in the vessels for clotting factors and the plasma. This now makes a child high risk for bleeding since there is not enough resources to clot the blood. Dehydration can happen quickly in cyanotic heart failure. This is due to the incidence of high fevers, poor fluid intake, vomiting, and diarrhea. This dehydration can then cause the blood viscosity to increase more and could cause a clot that can block off a shunt, which causes no blood flow to the area. Hypercyanotic spells are often referred to as TET spells, which then can occur with a child diagnosed with tetralogy of flow. They are more common in children under 2, but they can occur in older children as well. They're more common in the morning and often after a child has eaten, defecated, or has been crying. The cause is unknown, but it's thought to be from an acute spasm of the right ventricular outflow. This will cause dramatic decrease in pulmonary blood flow, which will cause hypoxia and metabolic acidosis. Treatment includes calming the infant first and then placing them in that knee-chest position. This will increase blood flow throughout the body. In an older child, you can have them squat to get the same results. A cardiac assessment should take place in a quiet environment with good listening so you can assess accurately. You will need to get a good history of what has been occurring and any treatment measures. Box 46.2 does a good job explaining the cardiac assessment. Some areas are at a more advanced level. It's hard for many nurses to identify murmurs or other cardiac abnormalities without some experience. If working in a pediatric hospital on a cardiac unit, you typically will take extra classes or have extra training, but all nurses should feel comfortable with basic cardiac assessment. This includes make sure you are talking and listening to the parents. Many times you have to ask detailed questions. They may not think to tell you about the shortness of breath or some activity intolerance. You'll inspect, things you'll inspect are nutrition. They could have failure to thrive or FTT. Color, you're going to note any cyanosis. Chest deformities, they could have an enlarged heart. Unusual pulsations, you will monitor for visible pulsations of the neck veins. Respiratory excursion, the ease or difficulty of respiration. You'll look for clubbing of the fingers. When you palpate, you'll palpate the chest, the abdomen, so you're going to look for hematomegaly or splenomegaly, and you're going to check peripheral pulses. Cardiac cath. Diagnostic is used to diagnose. Many times this is done before surgery in an infant. Interventional is used to make changes automatically. Example, dilating stenosis vessels. Complications can occur during the procedure and after and include dysrhythmias, hemorrhage, vascular damage, vasospasm of the centralized vessel or catheterized vessel, thrombus or emboli formation, and infection. Pre-procedural care includes accurate height and weight, obtaining allergies and reactions, assessing for signs and symptoms of infection. This is a crucial part. Assess and mark pedal pulses before procedure. Document characteristics of the pulses. Baseline vitals including pulse ox, skin color, noting any cyanosis. Prepare the child and the parent. Simple explanation of the procedure to the school-aged and adolescent. Explain what they will experience. You can tour the facility ahead of time if they're able to. Post-procedural care includes a recovery in a recovery room or their hospital room. They're on a cardiac monitor and pulse ox for the first few hours. You monitor pulses. You're going to do this distal to that cath site. You're going to note the temp and color of the affected extremity. Vitals, you're going to do heart rate for 1 full minute. Blood pressure, because hypotension can mean hemorrhage. You're going to look at the dressing, fluid intake, blood glucose levels. Depending on policy, you will need to keep the extremities straight for 4 to 6 hours. It can be on the parent's lap. Start with sips of water and advance as tolerated. Encouraged to avoid to excrete the contrast and monitor for signs and symptoms of infection at the site. Upon discharge, instructions should include inspecting the site for infection and when to call the provider, no soaking in the bath for the first 1 to 3 days after the procedure, showers or sponge baths are recommended, avoid strenuous activity for 1 week, return to school the 3rd day after the procedure, importance of taking antibiotics before dental procedures or other specific treatment measures, and follow up as scheduled with the cardiologist. Prepare the child and family for an invasive procedure. So pre-op should include the child and the family. How much info given to the child depends on their cognitive age. Keep things simple but include them. You must provide coping techniques to both the parent and the child. Depending on the procedure, it can be outpatient or inpatient. Either way, labs are needed prior to the procedure, and so they will educate on those if needed. If time permits and the child is old enough, tour the facility is beneficial. They need to know what kind of sounds they'll hear, like from the different monitors, where will mom and dad be before and after surgery, telling parents how their child looks afterwards. Many are shocked after when they see all the tubes. Provide education in various ways as far as verbal, written, videos, cartoons. Show them the blood pressure cuff, pulse ox, etc. If a play area, show them that as well. Talk to the parents on how the child will probably be sedated for a while. If it's cardiac cath, tell them about keeping that child flat for a period of time, and they may need a pre-op physical.